Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me from out of town. The patient had complicated cataract surgery, and then the wound had to be widened and removal of lens fragments, and then an anterior chamber lens was placed. The patient had persistent visual trouble as well as UGG syndrome, it seems like, persistent cystoid macular edema. There's also some corneal edema as well, and the pupil is distorted and dilated, and likely due to the ACIOL. And so you can see here, this is the case. You can see the pupil is distorted away from me here, and you can see the anterior chamber lens. Of course, it's really difficult to tell if the anterior chamber lens is in good place or not, but I suspected it was. Through gonioscopy, you could see that the foot plates of the haptics of the implant were into the peripheral iris and they were not seated into the angle. And so I suspected the persistent and recurrent CME, the patient's persistent visual distortion. And because of that large incision, the patient had over 6 diopters of astigmatism. And so I spoke to the referring doctor and said, my plan of attack is that they had a very large superior incision. You can probably see that on the left side of the screen, that this patient has some sutures there already on the left side, and that is through a superior incision. And so I'm going to actually make a temporal incision, a large incision, to counteract the astigmatism, hopefully, and also take out that anterior chamber lens and perform a Yamane technique as well as a pupilloplasty. So that is my plan of action. Again, over 6 diopters of astigmatism, visual distortion from the dilated pupil. There's some corneal edema, persistent CME. And so my plan of attack is to make a scleral incision that is going to hopefully offset the large amount of against the rule astigmatism by making a temporal scleral incision, large scleral incision, taking the ACIOL out, closing that incision, and then executing the Yamane technique as well as the pupilloplasty. So as you can see, I'm performing a temporal peritome, and then I'm performing some limited cautery. You don't want to do too aggressive of a cautery because the bleeding does help with securing the healing of the incision. And this is about, I believe, about a 6 millimeter caliper setting. I'm using ink marks. I'm using the crescent blade, and this is essentially like an extra cap technique where I'm making a scleral groove. You can see I'm about, 3 millimeters from the limbus. You need to really make a pretty deep scleral groove. If you make a shallow groove, then you're wasting your time because it's not going to be a very strong scleral shelf. So you need to go deep enough without perforating. And then once you're in, you dig deep with the crescent blade, and you're able to find a nice lamellar plane. And then you start to very gently go across from side to side. And you want to make sure your forces are parallel and within the incision. And you want to make sure you're parallel to those lamellar fibers on the sclera. And if you lift while you're doing it, you might actually make the scleral shelf too shallow. You don't want to dive down because then you might perforate into the anterior chamber. And so that looks pretty good. So I go ahead and make my paracentesis incision, and then I'm injecting some dispersive viscoelastic. I place some dispersive viscoelastic within the incision as well. And I do that because when I put my blade in, if I have that viscoelastic, it creates a little bit of a gap so that I don't create another second incision through the scleral shelf. And once I go in with the diamond, and then I go ahead and widen with the crescent blade. And in that regard, the metal blade is a little bit better because it's going to be less likely to create a second pass on the blade. You don't want to have 2 passes through your scleral incision. And once I've made that incision, I'm going to go in and grab the proximal haptic of the ACIOL. And this is a 2-handed microforceps technique here. And I'm able to very gently externalize that proximal ACIOL haptic, including the tip and then the elbow. And then I'm grabbing the distal ACIOL haptic there, trying to make sure that it's not incarcerated in the iris, and thankfully it's not. I'm using the forceps in the right hand to pull it out, and I use the forceps in the left hand to protect the corneal endothelium. And so you saw that maneuver. As I was pulling with the right hand, I made sure the forceps in the left hand was guarding the cornea. It's very important because as you're pulling it out, you don't know, you're holding it with one hand and one point and just don't know what's going to happen as you pull out that lens. So protecting the corneal endothelium with the left hand is just an easy and smart thing to do when you're taking the lens out. And I go ahead and close the wound because I'm not going to use that wound for the Yamane. I don't really think it's wise. It's a big incision, and I feel confident to execute the Yamane through a limbal incision, and I'm able to place the sutures through, again, that's 10 nylon times 3, and then I'm closing the conjunctiva as well. And so I'm basically trying to do this surgery in a staged manner, and I did the removal of the lens, and then now I'm going to execute the Yamane technique. I make my limbal mark, marking 180 degrees away. I'm using the tip of this cannula, which really creates really nice round and small marks. I'm going 2.5 millimeters posterior to the limbus, making sure the surface is dry, making sure I'm radial with the mark, indenting the sclera, and then placing my ink mark right over that mark on either side. So again, marking on the right, and then marking 2 millimeters adjacent on the right side and then the left side, and making sure that those marks are radial. This is my limbal incision with the paracentesis blade for my AC maintainer, and this is the paracentesis incision 180 degrees from my main incision for the externalization of the leading haptic. So that's my 20 gauge Lewicki AC maintainer going in. It does require a little bit of effort, but the more effort means the tighter the fit, which means a more secure AC maintainer. So I'm marking about 4 millimeters back, holding with the cotton tip, tunneling about 2.5 millimeters, tunneling to the sclera, and then turning near perpendicular and then entering. And the sign of a self-sealing trocar scleral incision is when you take the blade out and the trocar sits slightly tilted in the sclera. And so I'm doing a 2x speed of my vitrectomy here. But again, this patient already had a vitrectomy by their other surgeon, and so I just wanted to be a little bit thorough, and I'm doing a little bit of extra vitrectomy. And even though there's no vitreous here, I'm just wanting to make sure where I'm going to place my scleral needles is definitely clear of any vitreous. And as you can tell, I did rotate my chair, so I'm sitting more supratemporally versus when I did the ACIOL explantation. So I'm placing my incision, and then I'm going to go ahead and make my 3 millimeter incision that's going to be contra-incisional to the incision for the externalization of the leading haptic. I am bending my needles, first on the right needle and then the left needle, and I make sure that the needle bend is going to be facing the approach of the haptic. Here what you can see is after some manipulation, the mark actually moved. And so again, going back to what I've always said, the conjunctiva is a mobile structure, and you always have to reassess whether or not the conjunctival mark reflects where you want to place the needles through the sclera. And so this is my lens. I like to make sure that I load the lens myself when I'm doing the Yamane technique. And I'm pushing and advancing the lens here. I'm going to place my 25 gauge needle, which is again contra-incisional to my main 3 millimeter incision. I'm placing the injector bevel down, turning it towards the left. As my technician advances the lens, the haptic is coming out, and I'm docking it on the bevel of the needle. You can see I'm rotating the needle slightly so it's going to come out nice and flat, and then it goes out of the eye very nicely. I go ahead and advance the optic and then make sure the trailing haptic comes out pointed to the right. I'm holding the trocar to keep the eye in the neutral position. You can see how my needle is bent, and I'm tunneling and then diving in to the second mark, making sure the eye is in the neutral position so that the scleral needle placement reflects where I want it to be placed. When you see that the trailing haptic is too pushed out, you can see I just pulled the leading haptic more out and I was able to have a better exposure. You can see how easy the exposure is by doing it this way. Again, docking the haptic on the bevel of the needle, and it went right in to that 30 gauge thin wall or large bore 30 gauge needle. I'm disengaging the needle from my syringe, making sure it falls down without causing any weird movement of the lens. Internalizing the leading haptic with microforceps, holding the eye in the neutral position with forceps. I'm piercing the sclera through the first mark, tunneling 2 millimeters, and then diving down, making sure I am in the same plane before I rotate so that I don't hit the ciliary body. Switching to the microforceps, grabbing a little bit further than you think, because again, I'm going to grab, flatten out, dock it, and then advance the haptic into the needle. Once I do this, I turn the needles in the direction that it was pushed through the sclera. The left one goes down, the right one goes up. And once I have it in this position, I externalize, grab with the microforceps before it comes out too much. And then I'm going to cauterize the tip here, create a small bulb there, and then go ahead and pull out the right side one as well, grabbing the tip. And again, you want to make sure the forceps are ready to grab. You don't want to be fumbling around and then worry that it might slip back into the eye. And you can see the haptics are fairly flat. And when they're fairly flat to the sclera, that tells you you have a nice shelf, which means it's going to be an excellently positioned lens. When you see the haptic pointing up, that means it's a very bad technique, and the lens is actually going to be sagging down. The optic is going to sag down if the haptic is pointing up. And that means you have an inadequate scleral shelf. So again, a well-centered and positioned lens. I'm just assessing to see if I'm able to do the pupilloplasty, and I'm just grabbing that peripheral iris. What has happened is the feet of the ACIOL haptics really caused a lot of fibrosis to the peripheral iris in that area. And so I'm going to do a pupilloplasty the best I can. This is first some intracameral triamcinolone, just to ensure again that there's no vitreous in the anterior chamber. And thankfully there is not any vitreous in the anterior chamber. Go ahead and remove that Kenalog in the anterior chamber with the vitrector again. And you know, it doesn't hurt to have a little bit of triamcinolone at the end of the case, especially since this patient has cystoid macular edema. I'm pushing some myocol or myostat just to see if I can bring the pupil down a little bit more again. And then these are my incisions for the pupilloplasty. You always want to make your incision that's going to make it easy to do the pupilloplasty. Don't try to take, oh, I got a paracentesis here, why don't I try to use that? It's going to be very, very difficult to perform the pupilloplasty that way. So you need to make the incision strategic to allow yourself to do the pupilloplasty. So I made another incision and I'm using a cannula to help dock that needle on. Here it is. I had forceps and I switched to the cannula. And what's nice is you can basically push the needle into that cannula, which helps to externalize the needle without incorporating any corneal fibers in that needle pass, and then you're able to pull it out here. And so I'm going to use a bond hook to grab the suture on the other side. And again, I think this is a 10-0 or a 9-0 Prolene suture. And then we're going to perform the single pass fourth row pupilloplasty. So you can see here, I'm going to try to grab the end of the suture and then basically wrap it around through the loop 4 times. So I think, I don't know, that's hard to see that suture, it's so small, but I've done it 4 times at least, and then I'm going to grab the tip on the left side, and then on the other side with the right hand on the suture on the distal side, I'm pulling. It causes the loop to slide into the eye, and now I've created the pupilloplasty. And then I'm using micro scissors to cut the ends, and that is the extent of my pupilloplasty. And so by doing it this way, you can see that this dilated and distorted pupil was larger than the optic, and so the patient was having quite a bit of double vision, triple vision, quadruple vision. And so by doing that pupilloplasty, the patient did notice that double vision, triple vision, quadruple vision was much better. You saw when I pulled that trocar out, there wasn't any fluid coming out. Again, it was a nice self-sealing trocar, and you know this because the trocar was sitting slightly sideways, which means there's a nice scleral tunnel when I placed that trocar in. You saw I was removing some more viscoelastic, and I placed the suture, and I'm hydrating my incisions. And this suture, I have to place, that's through the AC maintainer. It was leaking a little bit. And so, of course, if you have a leaky incision, you got to deal with it. That AC maintainer incision is pretty tight. And again, you saw me wiggling it down, and it works great in that context because it's nice tight incision during the case. But in sometimes when you have to really put force in, it does cause it to gape. So I go ahead and place that suture in at the end. Thankfully, this patient did quite well. Again, the patient had over 6 diopters of astigmatism. At the end of the case, the patient's astigmatism was reduced to about 2 diopters. And so the patient ended up like a -2 +2 at the end of the surgery. He was best corrected around 2030 or so. I did prep him way before the surgery that he may need to have an endothelial keratoplasty down the road. The patient went back to his referring doctor and was quite pleased with his experience, but thankfully this patient did quite well and was happy at the end of his surgery. So I hope this was helpful to you, and I thank you for your attention.